is that don't use English classification. It's simple, but doesn't work. Okay? A lot of misleading information here. Now, if a patient comes to your office for orthodontic treatment, the first thing that you need to do before you are doing any further is an examination of facial appearance. Okay? So for the facial appearance, the patient comes to your office. The first thing you need to have a facial appearance. Okay? Facial appearance, especially the natural view of the facial appearance, is critical. Don't look into the dentition first. You have to look at the facial appearance first. Okay? The facial appearance, we have three in the lateral view. We have three categories. Okay? Protrusive or convex, straight, and concave. Right? Now, what we talked about describe the first session is all about that category. Okay? Now, if the patient comes to your office falling into this category, this is the thing that we will be talking about for the second session. We call it facial concave or facial concavity. Okay? The middle face is quite flat. It's indicating that growth of the maxilla is quite inadequate with overgrowth of the mandible. Okay? Sometimes both. And also, if you look into the front view, you could have the facial symmetry or facial asymmetrical facial appearance. And if the chin point deviates from the middle line. Okay? Now, and the second thing, you have to look into the self-remapped view, the head view. Don't always measure lots of the data. You have 100 data or something. Information is very limited. Okay? I mentioned again, we have to take a look at the morphological analysis of the mandible. Okay? Right. For the human being, we have to look into the mandibular morphology through the head view, going through the three parts of the assessment. First of all, geometric contour of the mandible, and depth of the symphysis, curvature, and also broadness of the chin. Okay? Take a look. For human being, be it Caucasian or Oriental, they always have two morphological forms in the mandible. First is the mandibular. In the mandible, we call it rectangular and flat. Now, if we draw two lines, okay, one is like a occlusal plane and one is mandibular plane. If these two lines are quite parallel with each other, we call it rectangular and flat. Okay? And also we have a depth of the symphysis, if it's very deep, with deep symphysis or shallow symphysis. Okay? And the second category is that these two lines are diverged together with each other. Okay? Now if the jawline in occlusal plane or cortical, if these two lines are diverged with each other, we call it triangular and thick. The subtype is according to based on the depth of the curvature of the symphysis, with deep curvature, with deep symphysis or shallow symphysis. Only two morphologies of the human being mandible in sabermetric views. Okay. Now, after the assessment of facial appearance, after assessment of the mandibular morphology, and then looking into the intraoral, and if the patient comes to the office with the facial concavity, there's always having a common phenomenon that the middle face is not very full, it's a little bit flat, right? And also the mandible, especially the mandibular, the gonial plate, the gone area is a little bit like the curvature is not very obvious, but for this kind of the first category is we call it dental alveolar origin. The middle face is quite okay, right? In general way, we could see that the vestibular surface of the alveolar bone is quite thin. It's very thin. Some manifest. There always some like the roots have been quite quite obviously there are some roots like a contour, okay? And individually there are some regular, there are some regional crosswise between upper and lower division, okay, between upper and lower. There's no whole thing, there's no whole division, there's only individual teeth are crosswise. And the molar relationship is towards class 3, but not very totally class 3, okay? We call it dental alveoli because that kind of patient, although has some initial sign of facial concavity, but it's not very severe, and also because the cause of that particular category is not by genetic cause, it's by environmental or postnatal causes, especially the time when the mixed condition, the permanent condition replacing the primary teeth, there's something wrong with the displacement or replacement, leading to some individual teeth, like cross-bite. Okay? So this is the simplest category of dental origin. And the second one we call mandibular positional postural protrusion. Okay? The patient middle face is quite flat. The mandible is quite in the normal contour, and the upper thickness intraorally. The main thing about this category is that there's some inadequacy growth of maxilla, not too severe, right? And the mandible is okay, but the position is no good. We still remember that the first session we mentioned several times about the intrusive translation mandible. Now this is opposite. The mandible could either to be retrieved in the first session course, or either going forward in this session. Okay, the mandible have to go forward to take a look. Now, if you push the patient mandible, lift the mandible backward, you can also have edge-to-edge, always have edge-to-edge position, leading to the space in buccal segment. Right? So it's opposite. Okay, we call it reverse free depth. Reverse, we mentioned free depth in first session in the map pushing the free depth, right? With facial convexity. Now, with facial concavity, we also have quite a similar situation. The mandible is positionally transformed, right? Transformed, and then leading to a elongation below the incisors and then intrusion of the lower posteriors. But the direction is contrary to the one we mentioned in this first session. Okay, so you can always push the mandible backward to the edge, leading to a space in the buccal segment, indicating that the depth of curve speed is also very deep. It's deeper than the situation we mentioned in the first session with facial convexity. Okay? If the mandible retreats backward, the depth of the curve speed will be formed. If the mandible is formed protrusive position, leading to the depth of the curve speed. Similarly, that is more severe. Okay, it's more severe. Right? And the morphology of the mandible is very good in this category of the patient. It's flat, rectangularly flat. The second category. We call it mandibular positional or postural protrusion. Yes. And the third one is skeletal. Skeletal is a little bit complicated based on the inadequate or deficiency of maxilla, overgrowth of mandible, or the predominance of the either entity. We further divide the skeletal origin into these subgroups. Okay, first of all, maxilla deficiency with mild mandible overgrowth. The main thing is about the division of the maxilla, but the mandible is relatively normal. The facial appearance is such that the middle face is very flat, and the whole thing here is quite normal, right? And intraoral level, class 3 molar relationship, but the incisal like the relationship is not too bad, right? The lower incisors is not reclined linearly too much, okay? Indicating that overgrowth, the deficient growth of the maxilla, together with relatively normal growth of the mandible. Okay? And the morphology of the mandible is like what? Rectangular and flat, indicating as long as the mandible is rectangular and flat, you're always very safe. Right? So do not use angles classification. They are all class 3. Angle classification is too simple. Give you no information about what's kind of like nature or etiology of the appearance phenomenon, or what's the treatment of the plant is. There's no clue at all. Okay? Don't use angles classification. They're all called class 3. With class 3 relation, we have so many scenarios. Okay? And for the skeletal origin, if maximum efficiency with moderate mandibular overgrowth, the morphology from flat, rectangular to triangle. Okay? As long as it's triangle, it's not good thing. Okay? Now, if we have a maximum deficiency, is for sure, and the mandible is overgrowth as such, is not too severe, moderate. Right? So leading to what? Middle face flatness, yeah, okay, or even sunken or something. But this way, this angle is getting more straight, okay? There's no too much, it's more steep, right? Indicating the overgrowth of mandible. Now, the model relationship is getting, the class 3 model relationship is severe. They are always like upper and lower is separate together, separate with each other. And the lower incisal mutual correlation has been a little bit obvious. Okay? And the morphology of the mandible is what? Triangle. But look at the depth of the curvature here. It's very shallow. Okay? So the chain is, the direction of the chain is go backward and downward. Okay? Now, in that particular case, that particular shallow curve synthesis means that the prognosis is bad, but not worst. Okay? Not worst. Okay. Now, if we have a maximum deficiency with severe mandible overgrowth, indicated by the morphology of the mandible is triangle, but the depth of the curvature is very deep. The problem is the chain point is pointing to up, downward, and forward, not like that one. This is dangerous, the most dangerous type of the malabsorption with facial concavity. Okay? Right. The model relationship is always like this very severe class 3. Okay? Now, take a look. Dental, positional, right? Dental, positional, the morphology of mandible is not too bad. And skeletal, origin, mild mandible overgrowth, indicates the mandibular morphology rectangular and flat. And origin, skeletal origin, moderate mandible overgrowth, morphology of the mandible, triangle, but the depth of the symphysis is very shallow. Okay? And the worst type is the skeletal origin, severe mandible overgrowth, indicated by triangled morphology mandible together very deep curvature of the symphysis. Right. Okay. This is the classification system for cases with particularly with facial concavity. Okay? Now, there's a differential diagnosis. First one is anterior frostbite. We never mentioned that anterior frostbite simply as anterior frostbite. Everywhere frostbite. Frostbite means that the reverse coverage between upper and lower incisors. Okay? Now, it could be either by the first type positional protrusion or because of the skeletal differentiation or discrepancy between upper and lower because of the size. They all could lead to the reverse coverage of the incisor relationship. We have to differentiate between these two types, okay? Because nature or prognosis is totally different. Take a look. This is a positional crossbite. The crossbite is very severe. look like. Okay, but actually the nature is very gentle. Can push it back to the edge to edge, and then we can restore that position under the position. We choose a position. We can do the correction between upper and lower rotation. Okay. And now, if we have also have a cross point here, this cross point is inside the cross point much severe than that one. Because that one, we have the reverse free depth, we have a rectangular flat mandible, and here the reverse overjet is quite shallow, but the mandible, morphology mandible is triangle. Okay? This one is very gentle. We can have a total flexion. This one not. If you start your treatment early, it's not saying that you finish the task. Okay, you have to follow that a long time and all the way. When the patient gets into 15 or something, the mandible will be overgrowth again, leading the cross by the frontal teeth again. Okay, this is the differentiation between the two types. You have to differentiate the two types before you start the treatment. Otherwise, very risky. Okay, very very risky. All right. Now, if we have a positional crossbite, we could always push back the mandible, right? Parallelly push back the mandible, and we always have an edge-to-edge position, right? Now, if that crossbite is skeletal, we could what? We could rotate the mandible. That's the word. Rotate the mandible to edge, but the nature is different. It's a rotational. Right? It's not the parallel pushback, not parallel push. It's rotational. It's rotation, like clockwise rotation, and we could also go to the edge. But the property between the okay. The differential that the second one is paradoxical facial appearance. Paradoxical is that the patient coming to office complaining about the protrusive of the mouth, not indicating necessarily the true. Okay? So the patient's chief complaint is only your what? Your part of your treatment planning criteria. Okay? Now take a look. It's a true facial complex, facial protrusive appearance is true because it has the overgrowth maxilla, normalized class 1, overjet overbite is good. Okay, it's one of the category for malocclusion we didn't mention that in the first one because too much time. Okay, this is also the complaining with quite protrusive mandible, protrusive mouth. Now this one, the patient comes to the office complaining about the protrusive mouth again, but picture is different because molar is class 3, alright? And the morphology of mandible is no good, it's also the triangle, but this one is also triangle, and also we have a decompensation of the upper front teeth procline, okay? So leading to a protrusive mouth, but it's not true. Right? The nature is different. If we extract the teeth, that one is very safe, that one not safe. When you start early, extracting teeth, and then the overgrowth of the mandible will happen later, leading to a overgrowth, the cross bite again, okay? Because this nature, this kind of patient is the patient with what? With class 3 skeletal, okay? But the facial appearance is quite similar. Patients don't know it. Patients don't really have to differentiate. Okay? They're always having something that the middle face is not enough, right? And also molar was always class 3 tendency. And upper front teeth will be very profound, but this one is very straight. Right? Okay. Okay, so this is the table for classification. If you've had it, you can take it home message as take it home message. We need to be very careful because it's not as simple as angle classification. Any classification is very simple, but doesn't work. Okay? This classification is complicated, but it's not too complicated, but it works. It gives you the phenomenon, appear like a superficial phenomenon. Etiology of the facial superficial phenomenon, and also the treatment modalities one by one. Okay, if you have a certain classification, you must have a clue about how to treat the patient. Angle classification do not. Angle classification does not give any clue about proper treatment modality for particular class 1, class 2, class 3. It's not as simple as class 1, 2, 3. I never mentioned that class 1, 2, 3. We always mention adaptation with the facial concavity or convexity or facial straight. Okay. So, mandibular morphology assessment is critical. Okay? If the morphology assessment is not very important in the first session, but is so critical in the second session. If the patient is the malocclusion with facial concavity, you have to look into the morphology mandible because it's very critical. It's fatal. Okay? It's fatal. Take a look. They are all the malocclusions with like a class 3 tendency, but the mandible, in terms of mandibular morphology, they're different. Okay? Mandible, if they have a mild mandibular excess or mild mandibular overgrowth, is always rectangular. Okay? Now, if the moderate mandibular excess or moderate mandibular overgrowth, angle shallow. Take a look. And if it's very severe mandibular overgrowth, they have a triangle and D. Sorry. Just keep in mind, this is dangerous. And if you have a patient in your end starting early, you must be very cautious. Okay? Have you told the patient's parents about the future relapse tendency or not? Right? This one is bad, but not worst. This one safe, very safe. Although they are all so-called class 3 skeletal, okay? They are totally different. Okay, now in terms of facial cavity classification and corresponding mandibular morphology, okay? Take a look. Dental, rectangular. Positional protrusion, rectangular. Now, if a mild the mandibular mild excess overgrowth with maxilla, division maxilla, rectangular. Now, they are all rectangular, they are all very safe. And now from here, we have a division maxilla together with what? Moderate overgrowth mandible, we have a triangle shallow. Now, if we have a division maxilla together with very severe overgrowth mandible, that will be indicated by morphology of triangle together with D curvature of synthesis. What does this mean? As long as genetically allowed, the mandible will get bigger and bigger, just like a balloon, right? But this one, although it's getting bigger, but it's going backward. They have some limitation. For the mandible, flat mandible doesn't go too far, right? Very important. So don't just ignore the angle classification because it does not give any clue of the facial appearance. Angle did not notice the facial appearance. He only noticed about the models. Okay? Alright. So, for the mandibular morphology assessment, it's most critical indicator for prognosis assessment of that particular class 3. We call it class 3 if you want to call it. Okay? Prognosis. We never mention about prognosis about the class 2 or something because it's always there's no prognosis at all. Okay? Now for the class 3 or the facial malformation, the facial concavity, we have to assess chart growth tendency before you touch the patient. Right? Now we have a summarization again. Okay, the morphology mandible together with what the prognosis of the deformity. Rectangular always very safe. Triangle not safe, but it's shallow. Not too bad, but it's bad, but not worse. that this triangle D worst. Okay? Now, the aims of the prognostic assessment of growth pattern of early age patients with facial concavity. Now, what's the aim? To predictively and accurately determine the specific classification category, right? Because in the early age, the classification is not very clear. You have to have assessment of the morphology of mandible, and finally, you could have a determination about the final classification. Okay? And there, for a particular pre-pubertal child, okay? The earlier the age, the more difficult you will be having, okay? And more responsibility you'll have to hold. Early treatment is not a good thing, in my personal, right? As long if you don't know this philosophy, you will always think it's very simple. You can start as early as you can. But actually, as long as you start the treatment, the responsibility will be always in your doctor's side. Okay? Alright. Now, the methodology of the prognostic assessment of growth pattern for early age patients with facial concavity. Now, take a look. What's the method? Let's look at OPG again. OPG will be always good. Don't omit OPG. OPG tells everything. Okay? Even with OPG, you can determine the facial appearance without set. Right? What does it mean? For the condyles radius are lengthy and diverge. Okay? If you have OPG with your hand like that, the facial must be concave, not convex or straight. Right? It's very lengthy, it's very long. It will be sometimes cannot covered by the whole OPG. You have to cut here to make sure that the condyle will be appearing. Okay? So it's very lengthy. If the facial straight face indicate that it's not very sensitive. Now, this is for what the different length of the condyle and the radius between facial concavity and the convexity. Convexity is mentioned that in the first session. They're very thick. It's facial concavity goes like that. And the length, yeah. Alright, okay, we have supplementary medical inspection, rectangular and flat. We always have a dental alveolar cavity, skeletal mound, okay? If we have skeletal mound, we have a triangle and a shallow. The skeletal moderate, and we have a triangle and a deep with skeletal severe. Okay, we have a summarization of that one, and we need now is so take a look at it again. We have the association between morphology and severity of the prognosis. Okay? If it's rectangular and flat, we often fall into dental and skeletal mound. If a triangle and a shallow, or skeletal moderate, with triangle and a deep, wow, skeletal severe. This is morphology, this is category classification. Now, the age requiring the mandibular morphological prediction is chronological age 6 years and 10 years of age. That range of age is very difficult to determine the final classification of this particular case. I indicated that younger than 6 years of age, if it's concavity case, don't touch it. Don't touch it. Lots of things. Lots of things, okay? Take a look. If the patient comes to office with parents with 6 years of age showing the facial concavity, it's no difficult to have a determination of facial appearance, okay? Now, the most important thing before you start the treatment is to have a morphology assessment. Okay? Do you think the mandible is flat or triangle? The mandible is triangle or flat? Flat. triangle, but the fortunate thing is what the depth of the synthesis is very shallow. So the classification will be determined what this is a malnutrition with facial concavity with what moderate overgrowth of the mandible. Okay? So the classification there. This is not class 3. That all class 3. Class 3 doesn't have any meaningfulness. There's no meaningfulness. Okay? So you have to determine the morphology of the mandible before you start the treatment, because you have to tell the patient parents about the future prognosis. Okay? Now, the significance of prognostic assessment of the growth pattern for early age patients with facial concavity to determine the classification and to plan the strategies of treatment modality. Two things. I indicated that before you reach the classification of the deformity, don't start treatment. Alright? So as long as you have a determination about the category of the classification, then you could start treatment plan. The treatment plan for this particular patients is not similar to the one that we mentioned in the first session. The first session is all about malnutrition, 3 deaths. There's no too complicated treatment planning. Okay, we'll only put the essay will be always there. But here is not. We call it comprehensive and multi-stage treatment based on first visit age. Okay. Patients with facial concave facial appearance must be very cautious. Must be very cautious. You have to organize the treatment plan not just once for all. It's comprehensive, multiple stage. First of all, we have to divide several groups according to the first visit age. Did we mention about the first visit age in the first session? No. If the patient comes with the protrusion appearance, there's no need. Okay? But if the patient is come to the office with class 3, or so-called tendency, you have to decide which range of the age that particular case is falling into. Okay? Now, the patient coming to your office with facial concavity or class 3, the day the patient comes to the office is the determination of the day, at this day, exactly what's the patient's age, chronological, not skeletal, not level. Make it very simple, chronological age. Okay? We have 3 or 4 groups. The first age range 6 years, 6 to 10. Very accurate, okay? 6 to 10. You can accurate it into month, okay? And the second, 11 to 15. Third, 16 to 20, and 21 to 25, okay? So, these groups are not longitudinal. This is individual, right? If the patient comes into your office seeking orthodontic treatment with class 3 tendency, you have to determine, before you do anything else, you have to determine the age, right? The different age of the group, you have a different task. You have a different responsibility. You have a different way of communicating with the parents. All different, right? Take a look. If the patient comes into your office with class 3 treatment or something, the first, according to the first range, the first age, 6 to 10 years, we have a 3-stage treatment modality. Stage 1, stage 2, stage 3. The patient comes into your office like 7 years of age, you can start treatment as long as you determine the classification. Now, but you also have to take a look at the age, right? If the age is between 6 and 10, you have a multiple tasks. Stage 1, orthopedics. Stage 2, dentitional camouflage, dentition vision. Stage 3 is retention, but most likely some cases will have a recurrence or relapse. You have to retreatment. You have to do retreatment. It doesn't matter you have a retreatment. What matters about whether or not you have already told the patient beforehand about the possibility of relapse. You can't tell the patient, every patient, parent, it will be relaxed. It's meaningless. You have to accurately to the point. Exactly your child will be having how much possibility of the relapse. Okay? Right. So stage 1, stage 2, stage 3 is maybe it's not real. But if you have retreatment of the relapse, it's real. Okay? But the patient come to your office with that range of age, you always have treatment plan like that. Multiple stages. You can't finish it once for all. Right? Yeah. Anyway, but if that patient falling into the first age, you have classification of the mandibular positional protrusion. Protrusion is quite safe. Right? You can have a 3-stage, but you can make sure you know that the relapse is almost not possible. Okay? You still remember the second category? Mandibular positional protrusion, not skeletal. Okay? 10 years of age, which age range? With classroom now, tell me, 10 years of age, which group of the age? First visit age. First age group, right? 6 to 10. So you should have 3-stage treatment plan. Now, if the patient comes to the office with that age and the classification is like, now take a look at the intro, it's very severe reverse 3 death. Now, very severe reverse 3 death. The second step you have to assess is that this is natural, this is positional or skeletal, okay? Based on the morphological analysis of the mandible. Do you think the mandible is triangle or flat? Flat, right? And it could also have a very deep curve speed, and also have the edge-to-edge restoration, indicating that the classification is second one. The positional protrusion is very safe. Look like quite severe, but it's very safe. Okay? You can have a treatment for 3-stage or just 2-stage. It's quite safe. Okay? You can tell the patient, as long as you can start the treatment, after the finishment of the treatment, it's very safe. There's no possibility for the future relapse. For sure. You can't tell the parents everything. It's maybe relapse, and after the parents will not trust you. Right? It's for certain. There's no possibility of relapse. Right? So falling into the second one. As long as you fall into the second one, low risk of relapse. Actually, no. As long as the classification is correct. Okay? Now, it's like before, but just like the bond HTTP, we have bonds, bond occlusal, and bond occlusal where we did lots of patients 15 years ago. But now we have a clear version again with that occlusal plane. What? S10, I will call it. Okay, we mentioned that. So we have a restoration, we can push it back to the mandible, and then with that in place, the mandible will be holding in the backward position. Under that position, we can do the teeth-to-teeth correction. Okay? We have enlargement of the middle suture, and also we have the upper HG to encourage the growth of the maxilla. Right? And then we have teeth-to-teeth, the second stage. Right? And then we finish. Take a look. Initial 10 years of age, falling into the first group of the first visit, right? And then, because of the classification very clear, is positional protrusion is very safe. No matter how severe the appearance is, it's safe. Right? Now, initial, finish. Take a long time because the curve speed is very deep. It's much difficult for the group of the patient to be flattening the curve speed than the curve speed flattening in the first session. So, initial, finish, okay, in the middle of the tube. Okay, we have to see the space, how huge the space. To close that space is not very easy, okay, but finally we can close that space. Finish, go to your stage. Now, because this patient is a patient with short concave, so you have to tell the patient, parents about the possibility of the relapse. Now, as long as the classification falls into the positional protrusion, there's no relapse. Okay? You can quite for sure that this initial, finish, first follow-up 2 years after the finishment, and very frustrating. Alright. And we have 4 years after treatment. Very safe. As long as the patient passed through the 15 years of age is sensitive. Don't keep in mind, 15 years of age is a very dangerous age where relapse will be happening in that age, right? As long as the patient goes through possibly 15 or 16 or 14 like that, this will be very safe. I think I should take this. Good. And then I have to close up to. And then 14 years of age, the facial appearance will change very much. And then all the way to 18. After 18, do you still have the risk of relapse? No. Alright, so growth of spirit, that's the spirit of the later gone. So it's safe. Okay? Alright. So the mandible morphology doesn't change, it's getting bigger, but the morphology is not changed. It's always flat and rectangular. Okay? Yes. Alright. So the patient coming to your office falling into the first visitor age, first group, you must have the treatment a long treatment planning. If the classification is positional protrusion, there's no need. And you can tell the patient very clearly, very certainly, as long as they finish the treatment, this is what we have. Now, if control, you have to forget the positional and skeletal, although the cross part in front area is quite similar. Okay? Now, if we have that case, take a look. 9 years of age, first visit age is what? The first group. Okay? And then again, the superficial appearance of the front teeth does not matter very much. Okay? You have to take a look at the nature of the cross part, either positional or skeletal. Because positional is safe, like the first one, the one that I just saw. Okay? If it's skeletal, it's very dangerous. You can't just tell a patient, okay, I start treatment and then just correct the cross part. All of a sudden, it will come to the cross part. Okay? Yeah. By looking at, okay, they also it's different pathway, okay? Yeah. The critical part is the assessment of morphology of mandible. The mandible is triangle or flat or rectangular. You see, guys? It's triangle or rectangular. Triangle is dangerous. Okay? As long as the triangle is not rectangular, it's dangerous. So the crossbite is dangerous crossbite. It's skeletal crossbite. Okay? So you must be very cautious. Okay? You tell the patient, okay, maybe it's essential to have early correction, but not secure. I cannot guarantee that at the age of 15, the lower teeth will be covered the upper teeth again. Okay? That's for sure. Okay? Right. So we have to do this falling to the last one. It's not positional protrusion. It's skeletal crossbite. Okay? Yes. So you have to follow structurally stage 1, stage 2, stage 3. Okay? what we can do now, stage 1, is orthopedic mid-path suture extension and RPHG. After that, you can stop little there, and you have to do the stage 2, is about the dentition camouflage, either extraction or non-extraction. And after that, there's still the high possibility of relapse, stage 3. Right? So the important thing is not about how severe the patient's the nature is, that have you told the patient beforehand before you treat it, before you start treatment? It's very right? So we use that one. Did you still remember? We have a accredited ones like without any digitalization element that we have now. Clear version of one occlusal plan we call S10. S10. It's not S8. S8 is only a closal plan to hold the mandible into the position, usually backward position. Right? Backward position. Right? Now we also could have the combination with 10, 11, and 16. What's 16? 16 we have what here? Two with smarty bottoms. It's not cut. Cut doesn't work. The bottom. Did you see there? Two bottoms. Okay? Making sure we can do RPHG, the clear RPHG, and we show you later on. So this is clear RPHG. We call it as two bottoms together with face or facial mask, but inside is clear. Right? So this is the breakthrough, making it possible to the treatment or correction of the cartilage patients with clear aligner. Right? Very heavy. Now, so for this place, we have a class of S10 to hold the mandible backward as much as it can, and then together with what S6 to stimulate growth of the maxilla. Take a look. What we do is to have initial alignment together with what folding backward of the mandible backward and doing some extension. Right? This is the task that we are having for the stage 1. Right? Crossbite is deflected back to the mind. The correction of the crossbite is not necessarily all the way to be maintained to 50 years of age. It is still a possibility to have relapse because the nature of the crossbite is skeletal, not positional. Okay? You have to tell the patient about that possibility. And we do some further elaboration. Okay? Because it's mixed condition. So we finish here, and between the completion of this phase of the treatment until the start of the second stage treatment, there's nothing in the mouth, right? We should have a negative teeth. We don't have any placement of a clear aligner. It's safe. What you only have the pockets for observation of the permanent teeth eruption. After permanent teeth are totally erupt, we start second stage treatment, right? And maybe after that, we have third stage because relapse is very likely, right? Okay. Of course, the stage 1, we already have some results, okay, and after that we have stage 2. After the permanent teeth are erupted, and after finishment of stage 2, we are expecting stage 3. Very likely. Not like the first one. First one there's no likelihood because it's a positional crossbite. And now it's a skeletal, but as long as the muscle is triangle, must be very cautious. Okay? The more triangle of the mandible, the more likely there will be relapse. Okay, now with the mandibular positional protrusion or skeletal protrusion, whatever, we always push back the mandible as much as we can, and help the way to the recording, the wax recording. We make 4 steps, okay? For the mandibular advancement, we have 4 steps. For mandibular backward translation, we also have quite similar protocol. Okay? So again, okay? The first step, scanning of the dentition. The second step, to have a simulation of repositioning. In this case, you have to push back the mandible as mentioned possible, okay? And then wax placement, and then the second scanning, okay? The same. Take a look. The first step, scanning of the structure. Second step is to have a simulation of the new position mandible. This case is contrary to the one that we mentioned. In the first step, we'll push the mandible backward, not the advanced mandible. Okay? Push it backward on the edge, and then we have a criteria. We have a criteria for the new position of the mandible. Sagittal, incisal at the edge. Vertical, incisal close the lip. Usually, because it's quite enough. Because that's quite enough. The open vital buccal is much bigger than the mandibular advancement. Okay, so usually we do not open extra open right in the front teeth. And the middle one is always the same. The mandible is not shifting to either side. Okay? Very simple. So new position of mandible in this particular category is like that. Push back the mandible to the edge of the edge. That's it. And the chin point will be overlapping with the facial midline. Okay? Good. And then we put the wax again in the front area and making the front area totally clear. Right? Okay. The same, okay? The same. Push back the mandible and make sure that the front teeth area is totally, but this one is, you have to close out the front teeth. Okay? Good. Totally clear, and then you have the push back the mandible as back as you can, and then instructing the patient to close out the front teeth totally, okay? And then that's it. So, alright, so the posterior area is the area for the second time, okay? So first scan, and we have the trial of new position of the mandible, the same, right? Placement of the wax, and the second time scanning for the new position of the mandible, right? And then we finish. Of course, this one is also quite similar. If you have the case with mandibular protrusion, you have maybe imaging is different, okay? Which have symbolically the same, directly similar to the one, okay? We just mentioned in the first session. All right, okay. So if the patient comes to the office with facial or palpable tendency at an age between 6 and 10, you should have the treatment plan in stage 1, 2, 3. Not missing out. Okay? 1, 2, 3. Responsibility will not be yourself. Okay? You write down that the parents take that one whenever they go. Okay? Maybe they will be transferred to other places, but that one is always there. Okay? You are correct. Okay, take a look. We have initial, okay. Please come to my office, 9 years of age. The crossbite is what? What's the nature of the crossbite? Do you think it's skeletal or positional? Do you think the crossbite is skeletal or positional? You guys must be very sensitive, right? Based on assessment of mandible, it's triangle. So the crossbite is much severe than if it's flat. Okay? So nature of the crossbite is what? Is skeletal, indicating it's still necessary to have a correct early correction, but it will be more likely when the patient reaches the age of 15 or something, they will have relapse. You have to tell the parents before 10, right? Otherwise, they will blame you for anything wrong. The parents will be very stubborn. Right? They will say, you treated them wrong. You have wrong treatment. Okay. We have orthopedic, we have orthodontic, and we have relapse, and we finish. All the way from 9 years of age to 19 years of age. Alright? So you have follow-up, 9 years of age, you finish in one stage, stage 2, and all the way to relapse, and you finish the patient 20 years of age. Right? It's a passion. For the treatment of the contact, passion, not about the benefits. I don't think you have the financial benefits of that. Right? It's a passion. It's a responsibility to serve the patients. Right? You have to follow up the patient all the way from 80 years of age or 90, all the way to the patient get to the 20. Right? Relapse is for sure. Relapse is for sure. This is different from the other patients with complex facial fluids. Class 2. Class 2 is very class 2. So the class 2 is safe. Class 3 is dangerous. Keep in mind. Okay? If it doesn't work, I think we have to change the do you have any control? Or who can manually control? I hope tomorrow or the day after I have such a situation. Yeah? Alright, now if the patient comes to your office with the age falling into the second age range, 11 to 15, we have 2-stage modality. Okay? Now, still memorize, if the patient is coming to the office between 6 and 10, 3 stage. Right? Now it's 2 stage. Stage 1, orthopedics followed by orthodontics. Okay? That's continuous. We do the orthopedics, we have the RPHG expansion. Immediately after that, we have that camouflage condition. Okay? And the second stage is not real, but if there's relapse, we will have a second stage, retreatment. Right? Yes. Initial 11 years of age. What's age range? The first visit. Which group? You guys agree? Now, 11 years of age is the first group or second group? The first visit age. Second, right? Second will be 2-stage treatment, not 3-stage, okay? The first stage is a stage where we have real treatment. Okay, now cross-bite again. Do you think it's a triangle or flat? Triangle, very dangerous. Okay, it's for sure. Although it's quite essential to have early treatment, but not guaranteed that in the future there's no relapse. It should be having no relapse. Okay. 50 years, 40 years later, we finish the orthopedics followed by orthodontics. Relapse, about 50 years of age, relapse. Patients know that. Patient find that the crossbites appeared again, okay? We have retreatment and we finish 18 years of age. 2 stage. Stage 1, take a look. We have a patient here. We have a stage 1 orthopedics followed by orthodontics. Stage 1, and then we have retention. But during the retention time, you already informed the patient about the possibility of relapse. You don't be nervous, okay? When the patient comes to your office again, don't be nervous because you already told the patient that will be most likely you will be having a reoccurrence as the crossbite. Okay? So we get into, and then, would you? Someone can It's very frustrating. I hope that tomorrow, the day after, there's not something like that, okay? It's frustrating. Why? The laptop should be in the front hole. That would be much better. How do you work? Would you please just press? Yeah, press. Good. Okay. Then that's 15 years stage, and then we have retreatment. The second stage. Now stop. Okay. So we have from the 11 years stage all the way to 18 years stage. We complete that case. Okay. So the first stage, completion first stage, not necessarily indicating that I finished the task in the future. Right? But the first stage treatment is very essential. Without the first treatment, you may not have such good result. But the retreatment is very simple actually. Now with the GS it's much simpler. Yeah? But the important thing is that you have to tell the patient about the likelihood of the relapse, because this is skeletal, not positional. Now, would you please have the next one? All right, take a look. What I said, that finally, the OPG, stop. The OPG will not accommodate the whole thing. You have to sacrifice the body, make sure that full exposure of the TMJ. TMJ is very important, okay, because it's huge. Right? Next. All right. Next, not going back. All right. Okay, so now, if the patient comes into the office, age, range, and the classification is positional, very safe. You can either have 2 stage or just 1 stage. That's for sure. Right? Okay. 11 years age, what's age range? The first or second? Second. The first is 6 to 10. Second is 11 to 15. The third is 16 to 20. Right? Okay. Now come to your office again with class 3 tendency. Now, the reverse 3 depth, yes, of course, but looking into further about morphology mandible to make sure what's the nature of the crossbite. I say again, there's no simple crossbite. You have to divide them, differentiate them into what? Positional or skeletal, okay? They are different, right? And by further looking into the mandibular morphology, and then of course you can have to edge to edge, right? So mandible retrusion simulation is very important. This is the way, this is the simulation telling you exactly the spacing bubble side is enough or not when you have the recording, wax recording, okay? Usually they just have edge to edge, right? It's quite enough. Do you think it's safe or not? You have to have a sensitivity about looking to the morphology mandible. It's very safe. It's flat. It's flat, right? You can tell the patient not too serious about just frightening parents, because we tell the parents it's although it's very severe, ability to have a total correction. The likelihood of relapse is slim, very slim, okay, very small. S10, because this clogging is very severe, I think it is really quite clogging. Alright, so the first stage we have S10, we have S6, okay, S16, and what? Take a look at here. Just keep it here, there. S11, okay, S11, S11. So this is a perfect combination of S10 for the position and representative mandible, S16 to what? Stimulate the growth of maxilla, and S11 to what? To expand the maxilla. They are all necessary. Okay? Yes. Next. That's it. Now, after phase 1 finish, okay, the stage 1 are the two phases, okay. Phase 1 is the S10 and clear awareness. Now, the severe problem is so severe, we have to resort to the extraction because this is beforehand we have already happened. After the extraction teeth, because the compliance of the patient is not very good, so we transfer it to fixed appliances. Okay. The next. Now, after the first phase is have you changed? Take a look. The next. S10, very important. Right? So this is a procedure you can't miss out. You have to do the orthopedics because the nature of the patient's malfunction is about what? Deficiency of the maxilla, little overgrowth, or very slight overgrowth of matter because it's a positional protrusion. It's very safe. Right? If the patient doesn't have such a severe problem, we will be finished all the way with what? With clear awareness. But the problem is so severe, we have to resort to extraction. It's all right. Okay, it's all right. Now, take a look. Next. Next. We can't alter the morphology mandible and the size of the mandible. Okay? So morphology mandible is all the way flat, always getting bigger, but morphology of mandible doesn't change. Flat, rectangular, very safe. Okay? Very, very safe. Okay? Now if it's triangle, you have to tell the patient that relapse, in the future relapse is very likely. Okay? Alright, okay, next. Now, extraction. Next. Okay, we have extraction teeth, and we have a line. We have transport to fix the appliances, and then the next one. Next. Okay, so we finish the case. Now here. Next. It's very. Okay, so S10 is very essential. You can't just jump to the extraction of teeth. This doesn't work, okay? Right. Next. Yeah. All right. Next. Keep it going. Keep it going. Keep going. Yes. Finish. So the first stage, should be having two stages. But if the patient falls into the category of the positional nutrition, single stage. Within that single stage, we have two phases. Phase 1 is orthopedic. Phase 2 is orthodontics. Division to division, right? It's very clear. You have to have a very clear treatment plan. Next. Next. All right. Because the mandible is not having any overgrowth element. It's very slight. So the length of the condyle altogether length is quite relatively normal. Okay. Next. Next. Beautiful morphology mandible, isn't that? Very beautiful. It's a flat and rectangular. Memorize that morphology. It's very flat. Right? Although in the original it's very severe, but actually the nature of the mandibular is very gentle. Next. Okay. Yeah. Next. So we have a review here. Okay. Stage 1, stage 2. If it's skeletal, you have 2 stages. You have to emphasize the possibility of a real stage 2. That's for retreatment of the relapse. Okay. Next. Again. Now, if we have the second visit stage is the most scenarios in our clinic. Okay. That range of age of the patients will be numerous. Okay, so we have some more cases. Now, if the skeletal origin cavity with moderate mandible overgrowth, means that triangle shallow. Alright? Stage 2, you have to plan the stage 2 stage. Because stage 2, the real stage 2 may be quite, not, because it's shallow. Right? Morphology is shallow. It's like triangle, but it's shallow. Take a look. Next. 5-year stage, 2 stage, right? That look about the morphology. Take a look. Yeah. Third up. Next. Next. Now, the crossbite, I say again, okay? Crossbite doesn't matter whether or not have frontal crossbite. That what matters is the morphology of the mandible, the nature of the crossbite. It's positional or skeletal. Total different stories. By looking into further morphology mandible. Next. Do you think it's a triangle or flat? It's triangle or flat? Triangle. Shallow or deep? Shallow or deep? Shallow. Means it's not too good, but it's not too bad, right? Maybe there's some relapse, but it's shallow. It's not too severe. Okay, next. Next. So falling into that category means that we should use the next, the orthopedics immediately followed by orthodontics. Okay, next. We have the RPHG because they have a crossbar. As well as the crossbar, we always have the occlusal plane. Right? And then next. And then because of some missing, that teeth missing, we have the extraction of the lower dentition. Next. And finally we get that. Right? Because the nature of the crossbars is triangle, but it's shallow, is bad but not worse, okay? You still have a likelihood of relapse, but the possibility or likelihood of relapse is quite slim, quite small. Next. Alright, we're finished. 15-year stage, starting 12-year stage. Next. 50-year stage is sensitive age. If it's a relapse, it will be relapse. If not, it will be safe, okay? Next. 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 Alright, we have changed the visual appearance. Okay, next. Not finished yet. We have to follow up for another 2 years or 3 years. Right? Otherwise, you are not finished your task. Next. Alright, take a look. Morphology of mandible is what? Triangle, shallow. Triangle, shallow. It's getting bigger, but there's no differentiation in terms of morphology between these two ages. Yeah? Okay. Next. Wait 3 years after treatment, we have a follow-up. Now, there's some relapse in this particular area because of the decision tooth is too big, right? Otherwise, it's very safe. Now, with 18 years of age, do you think it still have possibility of relapse? No, it's very safe. Right? So there's only one stage. The second stage is not real, although you already told the parents about the possibility of a second stage, which is supposed to be have a new treatment after relapse, but there's no relapse. Okay? Yes. Good. All right. Safe. Okay. That's it. So this is the patient, typical patient falling into age between 11 to 15. Take a look. All the way. The morphology mandible is triangle but shallow. Triangle and shallow is better than triangle and a deep. Keep in mind. Okay? Very useful. Very, very useful. It's make you safe. Right? Good. stage of the patient, skeletal, severe, deep, deep. 30 years of age, the second range of age, because of first visit, okay? And there's some deviation. Be careful about the length. That means that the length is indicating that very severe. The mandible is keep growing. Okay? Do you think it's triangle or flat? Triangle, deep or shallow? Deep, very dangerous. Very quite deep, okay? Very deep, like that. The chain point is to forward and downward. Quite notice the dangers, the danger of that patient, okay? Now, we have a stage 1, stage 2. Stage 1 is real, stage 2 is not real yet. Stage 1, we have 2 phases. Phase 1 is age 60, orthopedic, and phase 2 is dentition to dentition. Right? If you can decide the phase 2 will be having extraction, there's no possibility of relapse because the dentition camouflage with extraction will be quite stable. Can I take a look? So this is a replacement of cast RPHG facility. Okay, we have take a look. We make it possible to have RPHG with clear RPHG. Okay? There are 2 hooks. It's the hooks is very stable. It's very strong. Rigidity of the hooks is such that you have 500 grams of the force will be still holding there. Okay, it's very important. All right, so that procedure of RPHG is very necessary. Although you would have extraction decision in the second phase, but this one cannot miss that because the middle phase will be getting a little bit of fullness and a bit of change with RPHG.
Yes.
So with RPHG, we almost do not do any the individual teeth movement. Just hold the patient in such position, make sure that X16 will be working. Okay, good. All right. The second phase of stage 1 is that we have extraction. Sometimes the dentition to dentition stage is that either non-extraction or extraction. Right? But in the class 3, like class 3 cases, extraction, possibility of extraction much more than class 2. Okay? Yep. And we have a dentition to dentition. Now, we finish. Very dangerous. The mandible keeps growing. Still, the mandible is triangle and quite deep. But although it still keep growing, but it's quite because dentition is being matched with extraction, so it's quite safe. The possibility of the second stage is very slim again. Okay. All right. So the stage 2 may not occur because we have only extracted teeth. If we have extracted teeth, then we still have a second stage. It's very tragic. It's a tragedy. You have to make sure that after the extraction of teeth, there's no possibility to have relapse. Right? Okay. All right. Deep curve again. Okay. 15 years of age is the end of the second age range for the first stage. Right? Okay. There's some deviation anyway. There's partial crossbite. Now crossbite doesn't matter. What matters is its nature. It's skeletal or positional. Right? By looking into the morphology of the mandible, okay, right? This simulation. Okay? Do you think it's dangerous or not? Triangle, deep, very, very dangerous. Okay? But the good thing is that the age is reached to the end of the second age, 15. 15 is already the one that, the growth spurt is already finalized. So relatively it's still safe. So the philosophy is that the later the patient comes to the office, the safer. The earlier the patient comes to the office, the riskier. Right? Okay. Because that patient has reached to the 15 years age, so the second stage is the second stage, because the stage is very remote. Okay? Say it again. Now, S10, 11, 16. That is a very good combination. Okay? 10 to move the mandible, to reverse the mandible transversely and backward. Okay? 11 makes some extension, and also 16. We still use orthopedics at this age range. Okay? Good. It's very good. We have S10 plus sometimes. You have to use that. Because the other, like a liner or something, doesn't work for the position within the mandible. S10 is really useful, especially for deviation of the mandible. Alright? You hold the mandible in the right position, under this position, and the teeth for dentition to dentition. Alright? S11, take a look. S11 has appeared for the initial period, and after that we remove it, and we have a gradual reduction of the thickness of the occlusal gland. Means that we are doing the curve speed flattening, and also the crowding relief. Most important thing is that mandible is shifted to the right position. The middle line, then the middle line, finally should be on. Yeah? Okay. Initial, phase 1 finish. And phase 2 is what? To have an intercuspal relationship deliberation. That's much easier. Middle line is already on. Take a look at the middle line shifted how the middle line is very off, right? And now the middle line is on. Okay? So the separation of the packaging mandible is so critical. You can't just put the braces on, put the routine alignment on, hoping to have a correction of the mandibular position by elastics. Elastic doesn't work. Right? Elastics doesn't work. You have to make the whole mandible in the right position. Under that position, you could have some additional correction. Okay? Always 3 lines. Red line is facial middle line. Yellow line is upper dental middle line. Blue is lower dental middle line. They are not necessarily overlapping together, right? The final result should be there's one line. Right? This second stage is much easier. We finish. Almost in the same line, okay? Overlapping in the same line, okay? And this is the occlusal. Take a look. And we change the facial appearance, of course. And then we have facial appearance. That will be very important from frontal view. If it is deviation mandible, it's very obvious. Patient will be not happy with that. And then after correction, okay, the deviation of mandible is much improved. Okay? Yeah. Almost on. The chain is almost overlapping with facial movement. Although it's triangle with the D, but patient get into the 15 years of age, the danger of relapse is getting decreased. Okay? All right. Take a look. It's very yeah. Like the additional the additional one, and low inside, so the compensation is just like they are. The position is just for the so that we have to apply the low addition. Okay? 2 years follow, they're always very stable. 90 years of age. Do you think it's still a risk of relapse? No. 90 years of age. Good case, right? Alright, okay, so 11 and 15 years of age is the patient that we have most of the patients who are falling into that age. Right? The 11 years of age again, take a look. The facial appearance is not very severe, but don't overlook. You must be very cautious. Okay? Although the facial appearance is not obvious, take a look. The close point is very shallow and initial, and what did you see? It's triangle with what? Deep curve. The point, the chin point is in this direction. 11 years of age, in the very initial age stage, is high possibility of relapse. Okay? And according to the skeletal, now we have the stage 1 of 2 phases again. One is orthopedics, followed by what? The orthodontics, okay? And stage 2 may occur. Why? Because the age is very young, and also the curvature is very deep. You have to tell the patient beforehand the strong likelihood of the relapse. We have orthopedics, and we will have orthodontics, and we finish. Look like quite optimistically is quite good, but we never say anything optimistic because underlying morphology manual is really not good. Okay? So you have to tell the patient about the high possibility. Now, with the passage of age, with that time, the depth of the curvature is getting deeper. Right? Take a look, initial, and we're finished. Right? Dangerous. This area is going forward, allowing the mandible to grow as much as it can allow. Right? Get up, relax. Take a look. Take a look. We finish and we relax. But the good thing is that we already told the patient about the relapse possibility before we start the treatment of the patient. We told the patient that the likelihood of relapse will be happening in 15 years of age. Yes? See, it's true. The patient will not be very nervous, and you will not be surprised if the patient appears in your clinic again. Okay? You also need to charge. Relapse. 15 years of age. So, what we do? We have root treatment. This is stage 2. Right? A root treatment, and we finally finish the treatment. Alright? So, that's what we have. There's no possibility, there's no possibility to have a coverage of the whole, the length of the conduct. Right? Getting longer, take a look. Getting bigger. So rule number 1. At the very first day you see the patient, you must have assessment of mandible morphology, not just naturally the angular and linear measurements. That's the work. ACMA, ACPA, BI, lots of them. Okay, 100 data give you no information, right? Morphology does. Right? Morphology does. How big it is, how tall it is. Now the length, The more, the depth, the deeper of the curve, the synthesis, the taller of the patient is proportional. Yes? And also, so you take a look at OPG, you can predict how tall the patient will get. The very first day you saw, the patient is like, it's a small guy, small boy. And all of a sudden, 1.14. It's like, that's the more accurate. All right. 13 years of age. Facial appearance is not severe. Take a look. Triangle, deep curve, right? Be cautious, okay? Be cautious. You can start treatment, but you have to tell a patient that it's possibility that you could have ended up with that one again. Okay? As long as the depth of curve of the synthesis is deep, it indicates as long as the genetic nature allows, the mandible will be growing such that there is no limitation. Sometimes the relapse, the new treatment have to be resorted to surgery. So we always tell the patient the possibility of surgical intervention as long as the morphology of the mandible is triangle together with deep curves, the deep synthesis. Otherwise, it's still necessary to have early treatment, all right? Because if you finally you still need surgery, the surgical modality is much simpler than if you did not have any intervention. I can tell that. Right? This is a lesson. Okay? So don't never say promise the parents without the correction of the patients. The patient will be taller, like apples they get, okay, basketball apples. Okay, now if the patient comes to the office in the later stage, 60 to 20, the later the age is, the safer. Right? Patient, not very severe, but we still use orthopedics. Okay, it's like a pretty large shape, and yes, and we have a 16 because the third range age is still the age where we still use orthopedics. We will stop using orthopedics unless the patient reach the fourth age range, like 16 to 20. Otherwise, 16 to 21 to 25, where we never use orthopedics. But now it's changing again. We have MSE. Have you heard of MSE? You still could have with the plateau, suture, separation. Okay. Now we use that. Take a look. It's really accurate because you could have orthopedics together with orthodontics. They are merged together. Right? And sometimes we use 11 to counter the side effect of the 16. So hopefully the transverse dimension is not for the enlargement, not for extension. Okay? And then we have finish, and we have a second stage, it's much easier to take a look. We still have a very good outcome. Okay? So orthopedics is still necessary, although the patient is already like 30 years of age. Okay? Take a look. Still workable? Good. Still workable? Yes? Alright. So, it's very intense. Right? So have a lecture review. Okay, just have a review. First of all, classification, very important. Okay, classification, dental, positional, skeletal, mild, right? Skeletal, moderate, shallow, skeletal, severe, deep. You must have a classification like that. Not any classification, they are all class 3. Right? That's to have any meaningfulness. And then we have a correlation between molecular morphology and the deformity prognosis. Okay? Rectangular, always always safe. Triangle shallow, bad. Triangle deep, very, very bad. Okay? Relapse for certain, for sure. Okay? Or maybe with deep, you're always saying something about the surgical possibility. Okay? And with shallow, there's no indication. Indication for surgery is very weak as long as you have an early intervention. You can say very decisively, not say every patient will in the future will be possible evidence of the surgery. Just see how it goes. No, don't never say that uncertain things to the parents. Always certain, right? No surgical indication, very, very weak surgical indication, very strong indication for surgery. Okay? Yes. And also strategies of treatment modality is comprehensive and multi-stage. It's not once for all deal, right? You have to accompany the patient all the way from 8 to 20. Do you think it's worth? Do you think it's worth? Yes, we are orthodontists. We have to serve the patient, okay? But you have to make sure you have to prepare. It's a long battle, long time battle, right? Okay. So the range of chronological age is so important. Okay? If it's class 2, never. If it's class 3, you have to divide them into 7 groups according based on the age when the patient comes to the office. Right? First age, 6 to 10. Second range, we should recycle that, 11 to 15. And third one, 16 to 20. And 21 beyond. Very important. Okay? It's so critical. You have to, because every different range of age, like the different categories of the patient. I say it again. The first one is most dangerous one. Don't be overpleased if the patient comes to the office with a lot of early age. Right? You take lots of responsibility. If we don't have a clear classification and start treatment, and then all the way after that, the patient will blame you for everything adversary. Right? So you have to tell the patient exactly what will happen, what's the possibility of the happening. Okay. And then we have if the patient comes into your office, between the 6 and the 10, we have a 3-stage treatment modality, okay? 3-stage. Unless there's a positional protrusion, otherwise they're only 3-stage. You have to tell the patient to write down. Right? Although the stage 3 is not real, but lots of cases that is a real stage, real treatment. If the patient comes to your office between 11 to 15, 2-stage treatment. Right? The second stage is not real, but most of the cases will be real. Okay? And the third, 16 to 20, is only 1 stage. No relapse, no retreatment. What you saw is what you get. Right? What you get. There's no relapse. Still have the orthopedics. 20 to 25, only 1 stage. Camouflage, additional camouflage, or extraction. Relative extraction, lateral extraction is much higher, right, but safer. There's no relapse, no retreatment, no orthopedics. So the differentiation disparity between stage 3, the age, like age, third age and fourth age is orthopedics. Okay? The age between 16 to 19, we still use orthopedics. But the age 20 to 25 over, we will not use orthopedics, just dentition to dentition. Okay? All right, okay. Yes? We have a surgical case. I think professor will be having this orthodontic surgery department. Okay? Yes, if the patient comes to you like that, no the indication for surgery. It's not every patient is surgery. But if the patient comes to your office with 18 years of age, that severe, there's no way. It's what? It's take a look. you have to do surgery. Okay? Before surgery, you take a look, it's very deep. Yeah, that bloody image is terrible. But if the patient comes to the office with early intervention and expansion, the surgical procedure is much simpler than that. Right? There's too many segmental. There are 8 segmental bones, right? So this is what I tell you that patient, if the patient comes to the office in like 10 years of age or something, you have did expansion, the surgical procedure will not be so savage. That's the point, okay? Not the point about the surgery. We're never showing the surgical case, right? That's it. All right, so today is very intense, okay? So I have to finish the course and I will take some questions, okay? Thank you very much. Thank you very much. This is very intense. Thank you. Any questions from the audience? Yeah, okay. This is surgical. Okay, we never send the patient to surgery. Yeah. Okay. Thank you, Dr.
Yeah, you're welcome.
I think the course is too much stuff.
Dạ thì cái phần thầy giảng hôm nay thầy nghĩ là có pháp đề rồi là pháp có nhai đến gì dài á. Nếu sĩ có câu hỏi nào từ
em nhờ anh họ sẽ giúp em. Em hỏi thầy là về cái class 3 thì thầy dùng cái đánh giá triangle rectangle và cái rambus tương quan hai bên ấy thì nó rất là quan trọng trong cái tin lượng ấy, thì cái đánh giá đấy nó khá là định tính. Vậy thì thầy có thể chia sẻ cụ thể hơn không, bởi vì nó còn
định
tính
tính
hơn.
tức là thầy chỉ nói định tính thôi, tức là chiều cao hả?
Dạ.
Anh nói là chiều cao của hàm dưới đúng không? Hay là cái hình thái của hàm dưới?
Triangle rectangle với rambus hai bên.
Yeah, and Professor, you place very important emphasis on the morphology of the mandible. But do you have any quantitative measurement guidelines to classify what is a
We
triangle,
are
what
with
is
the AI
rectangular?
exercise.
Yeah, phải nói AI nó quyết định
It
cho
will
mình.
come out very soon.
Trí tuệ nhân tạo nó quyết định cho mình.
Gary will take responsibility for that AI. Right? It will
Cho
come
nên
out very
anh
soon.
Gary á, anh là bên kỹ thuật là
Computer will
AI á, nó sẽ
do
quyết
the
định
examination, not us. Okay? You don't worry. Computer will do that.
và
But we'll train.
nó sẽ quyết định cho chúng ta
I think very soon.
là vô cái tam giác hay là vô hình chữ nhật phẳng hay tam giác là dài.
Very accurate. Very accurate.
Và nó sẽ xác định một cách rất là chính xác. Cho nên thầy ông nói là chỉ số định lượng là bao nhiêu độ rồi nó như thế nào.
Maybe early stage of next year, the AI system will come out, okay? And you guys just know the basic knowledge of the morphology, but not such data that accurately you could have every examination. It's not true. It's not.
Dạ, cho nên mình chỉ cần có cái concept thôi là cái hình cái hàm dưới á, cái thân xương hàm dưới là chữ nhật hay là tam giác, còn cái tính năng đó sang năm nó sẽ trở nên rất là phổ biến. AI nó sẽ dùng mình. Giờ anh không biết nhưng mà câu hỏi nó hay.
Anyway, morphology is very critical.
Nhưng mà cái hình thái thì rất là quan trọng.
Much more important
Mà nó quan trọng
than the
hơn
measurement.
những cái số đo khác.
We have a piles of data.
Chúng ta có rất là nhiều cái dữ liệu đó, những dữ liệu mà theo cái này
Don't tell you any
nó
information.
không cho nói cho chúng ta cái thông tin gì hết về cái khuynh hướng tái phát, mà chỉ có cái hình thái, còn hình thái như thế nào để máy nó tính.
Okay, because the second part is more complicated than the first one.
Cái phần 2 tức là phần nói về mặt lộ nó quan trọng hơn, nó khó hơn cái mặt lộ. Mặt lộ là phần 1.
President of the association and also Dr. Chen, on behalf of all the participants, if you want me to come back again, I'm more than happy to have a 2 days course.
Dạ, thầy cũng thưa với ban tổ chức, ban lãnh đạo hội cũng như toàn thể cử tọa là nếu như có lời yêu cầu thầy sẵn sàng quay trở lại 2 ngày dạy cho nó tự động.
The precondition is that you must submit the case. You remember that? Do real time practice. Otherwise, theoretical things are too complicated.
Dạ.
Yes.
Cho nên cái điều quan trọng á, các chị phải submit cái ca lên cho công ty hỗ trợ. Các chị học mà nắm các cái lý thuyết mà không thực hành thì cũng như không.
Do you guys welcome me to come back again?
Dạ, các chị có muốn tôi quay trở lại không?
You will do that. Okay. Yeah. Maybe 2 courses for class 2, 2 days course for class 3.
Dạ.
Okay.
Dạ, cho
Yes.
nên phải có 4 ngày, 2 ngày cho cái mặt lồi là 2 ngày cho mặt lỗ là 3.
Alright, so we have a draw. Okay, we have a lucky draw. And what's the first prize? Yes. Okay.
Đi được không?
So thank you again. I see you next
Cảm
year.
ơn. Dạ, sẽ gặp lại.
Trước mắt chủ nhà.
You need you correct the overbite in the front, but in the back, they still have a lot of space. So and then you set up, we finish, and then we waiting for the second phase, the second step.
Yes.
So how they eat when they have the big space in the back?
Which one? Which one? There's one of them or which one?
No, the picture you show us. In the picture you show us,
Finish the first stage.
Yes.
We have a huge overjet.
yes, but we have the big space in the back.
Obvious place.
Yes.
Oh, okay. It's alright. It's alright.
No, you finish the.
Yeah, I know that. Yeah.
The-
Actually, they will meet you together very soon. Now, if the space is still there, we still could issue several alliances, make it a very thin proposal plan, and then they still can choose.
But normally, like the children, I follow some children have
Yes.
class 3.
Yes.
So if they don't have the touching in the back, it means like have no relationship of the molar, premolar in the back. So
Yeah.
normally they try, if they want to eat,
Yeah.
they have to move the lower
Yeah,
forward to
we should have
right.
put the picture there because we don't. They actually already meet together. It's very it's a change. It's exchange time, right? And the online people will push the to it's going anyway. We can live there for a very short period of time. Now, either you can wait for until the parent teacher will come out. It's not too late. But if we have early treatment, we should fix that dilemma. But anyway, if the space is quite significant, we still have to issue some nice link then link together. They with clear yes. You are very conscientious. You are very conscientious. Yes. You have a good English.
Em mình giống như em
All right. Thank you very much again. Okay. I love you guys. Okay, you are very conscientious, really ingenious, and it's great. Okay, and I hope that with this knowledge that you have here, you will be serving the patient more efficiently and safely. Okay, good. Okay, right, give it a laugh. Good. Thank you again.
Cảm ơn bác sĩ đã ở lại cũng mà đảo bên Scotland có cái 2 phần quà may mắn cho quý bác sĩ tham dự cái kỳ hội này bên chính sách. Thầy Anh Sen sẽ bóc 200 may mắn. Dạ. Anh đầu tiên là một gói điều trị Scotland trên không giới hạn 2
127.
127 ạ.
Đấy nhá. Còn đi lên phố mình có bao giờ chụp
Em bảo là em chúc này em tặng lại cho em chúc này em tặng lại.
Chào các quý vị, ngày mai mình sẽ có mặt là lúc 8 giờ. 8 giờ. Thì có những câu chuyện đây thôi, rồi gặp lại các chị lên các quý đồng chí sáng mai tại đây luôn.
có những cái cập nhật nhé.
Đây, ngoại quả.